Hi, good afternoon, everyone. As Sam said, so what we're going to be talking about here is how do you prepare your urgent care centers for those medical surges? Just some history. So, I'm one of the regional medical officers for PM Pediatrics. I also happen to also be in charge of emergency department accreditation for pediatrics for the state of Illinois. I'm the chair of that committee where we really look to see how we can make our sites ready for any patient that walks in the door at any one of the emergency departments, and also how do we extend that same knowledge and understanding to pediatric urgent cares. So we're going to look at the 4S approach. So that being said, for this, we're going to be going over, it's going to be looking at the toolkits and what is practice and how do you take that and make it into checklist resources and the other items that you need to make sure that your urgent care setting is ready for no matter which patient walks in the door, no matter which type of patient, no matter what events are happening. This is the next step in the work that NERUCA has done already. For those of you who are involved, know that they've already put out a checklist that we will kind of go over for pediatric patients, but how do you expand that to every patient around you in every event? So we'll go over some slides, go over some preparedness, and then afterwards there will be a question and answer section. So if anyone has any questions with this, please let us know as we go through this. So obviously, for those of you who are really here for any of our urgent care leaders, clinicians, operations staff, when we address a spike or a change that happens, obviously, if you have any questions, you can drop it into the chat. Sam and I will be looking at that. We'll get back to them. Also, at the end, we will have some time to have Q&A for live. And then we will go and share some material on, first of all, checklist worksheets, things that you can implement in your offices at your urgent care setting to really address preparedness for the future. So, what are our learning objectives? We're going to talk about what really are surges and how does that affect us. We're going to talk about the 4S language. So, for those of us who don't quality improvement, it's always good to have the same language. So, what are the things we can put into place, and what's the language we use to have a shared framework of addressing things? We're also going to look about what resources already exist. Why we're not the first group or area to be looking at surges, and so what can we take from that? What checklists, worksheets, and things that help support us in our work here? Being pediatrics, that is a special population. There's other pediatric populations that are particular, and what changes or roles are different for that pediatric population that can happen. And how do we talk about rehearsing with confidence? And then it says adopt with a roadmap. I like to think of it as I use the 3 A's. So whenever we do these things, are we going to adopt what we learned, adapt what we learned, change it a little bit, or are we going to abandon it and come up with a different project or different strategy that works for your urgent care? Remember that the goal here is to look at every urgent care, no matter if you're a single urgent care in upstate New York or you're a large urgent care in the city. How do you adapt, adopt, or abandon plans and things like that? So this way, from a quality improvement standpoint, we can improve every time. So our agenda for this is we're going to talk about why surge is important. We're going to talk about what those things are needed, why readiness is important. We're going to take a look at the toolkit that's already been kind of put together and what's in it. We're going to talk about this mentality and understanding of the 4S. So really looking staffing, stuff, space, and systems, and how each one of those are important when we look at surges and when we look at how things are progressing. We're also going to, like I said, address that special population, which is the pediatric readiness, and then look at that population and what the needs are and how things can change and what special instances we have to think about. Whenever we think about surge, we're going to talk about how we rehearse it, how do we implement it, and then what roadmap, what quick wins. And for those of us who've done quality, the old mantra is, what can you do by next Tuesday, right? What can you do to implement some changes in your organization quickly to really get you prepared? And then what long-term goals, what long-term ability, and then, like I said, we'll go into live questions. So let's jump right in. So why is surgeon readiness now? So the truth is, to be honest with you, urgent care is addressing and seeing more patients than ever before. So, and we know that surge is not rare. It happens all the time. For those of us who've done medicine, whether we're looking at different events, we're looking at different areas, and the fact that some of our, areas, we're seeing much more patients in our urgent cares than are seeing in the emergency rooms in the same area. So what do we do when we search, when we have a fixed amount of resources, when we have a fixed amount of staffing? How can we address it? How can we be nimble? You know, it's going to happen. And then let's talk about the surges that we know are going to happen versus the surges that we may not be able to predict. And how do we get ready for those? So when we're talking about really surge, we're talking about a few different aspects. There are the surges, like I alluded to, that we're aware of. Every time for respiratory season, there's going to be a different surge. For those of us who remember the RSV season, they came out of nowhere right after COVID. COVID itself, right? Versus influenza. And for those of us who remember right after H1N1, the following year, the influenza surge was in, February and March, which was not usual for that time period. So we know that these things can happen. We know that there's some understanding that they're going to happen sooner or how. So for respiratory season, you kind of know that that's going to happen. I usually think that from a staffing standpoint, I always want to make sure that, I look at that and other things, and we'll talk about the 4S's also. We have our emergency departments and they go in diversion, redirection. How are they doing with patients? We constantly get phone calls, and I'm sure all of you do, from patients who are sitting in the emergency room asking us what our wait time is because they're actually in the waiting room at the emergency department and want to know if it's easier for them to come to us. So how are those acting? What are things we can address, and what are things we can do? Then we have mass gatherings, whether it's tournaments, whether it's the FIFA World Cup, whether it's festivals, seasonal traveling. Those things draw intense amount of population into the area. Even if it's something simple like, if you're down the street from some one of the areas that does a medieval times or a reenactment, in Illinois, every year in Springfield, they do a large Civil War reenactment where thousands of people go into that area, and the hundreds of volunteers from the Boy Scouts in those areas go into those areas. So knowing that those festivals happen, are there things that you normally see? If you happen to be in Pennsylvania, um, for those of us who do paintball, there's a skirmish where thousands of people get involved in a paintball event. Are there different things you need to think about? What wounds, what areas, what happens on those events? If you're, working the marathons where you are you possibly going to have people come in because they're inundated? Or, when we had parades by us, there's unfortunately events at those parades, and are those, ERs inundated? There's, of course, public health emergencies, whether it's outbreaks, whether it's environmental smoking spikes, and even the heat every year, depending on when we have those sweltering heat. If your area is not well prepared, if the community is not adapted to be able to handle those. And then our own disruptions and outages, whether it's respiratory season and everyone's sick, if there's other outages, something simple like, what do you do when your power goes out? Do you have backups? How do you address that? Where would you offshoot those? So these are all surges that we have to think about, and we have to take the time to really think of, what do I need? What equipment do I have without overstocking? I always used to joke when I think of quality improvement mind, is that you also don't want to overstock. I used to go into some of the drawers and there'd be 90 swabs of things I swab once a year, but yet not a tongue depressor. So what equipment do you have? How can you surge up to get the equipment if you know you're going to have, like I said, if it's a runner event? Do you have enough, cold packs because there's going to be heat exhaustion? If there's a festival, or do you have enough things because there's more likely to have finger injuries depending on what the festival is? So how do we stock up without overstocking, but having the things to meet their needs? Or how can you search up or down depending? So that's looking at the why. So we know that this medical surges happen all the time, and there's lots of reasons why these things happen. So really we're at the front door. I used to work EMS, well, one patient at a time at the front door, but really we've become the next level. So we are really there when emergency departments are overwhelmed. I mean, we get phone calls all the time, and they divert lots of patients to us when the ERs are full because they know that they can't handle the amount that's coming in, and can we? All right. Also, what is our role? Really identifying who needs to be seen. So we're the triage. Who needs to be sent to the emergency room? Which patients can we actually address in our clinic, that we can address from an urgent care safely and doesn't exceed our scope? So those patients who fall, we have the ability to do X-ray and put on, a post-mold splint, for those, versus the patient who needs to have surgery and be addressed right away. So identifying what's critically ill, what resource utilization is needed, is really what our role is. And then obviously to be that buffer, also keeping patients away from the emergency room so this way they're not overwhelmed. They're not getting overwhelmed with the amount of patients that are coming in for things that, truthfully, as we say, muck up the pump, right? As things come in, if there's a lot of patients come in, I once had 9 people walk in for a strep exposure, and literally it was an exposure at it was a family event, and it was like 13 kids who all got exposed to somebody who got diagnosed with strep that day. It would have been much nicer to be able to say, hey, you know what? You can go somewhere else. So this way I can see the traumas or the other things that come in from an emergency room. Also, we have to think about, like when we talked about this, and I allude to this, you know, what do we need to have? What do we need to have when we walk in? Patient safety, acuity, what staff burnout. If it's truthfully, if you're not having enough staff, and when you go from, we already go from ebbs and flows from 0 people walking in 30 minutes to 9. We already deal with those surges as they are. But what if they triple and double? How can you offload some of them? How can you deal with those bottlenecks from what's coming in the front door? Are there gaps in your pediatric knowledge? Is there surfaces or things like that, that the pediatric patients are coming in? The thing that we have to realize, it's a different population with regard to those. How do we improvise? How do you have things already ready? If you're thinking about, I reminds me of a picture I once saw of how to fix a wing on a plane. And as this biplane's flying, somebody's out to try to fix the wing as they're flying, or fix a flat tire as you're riding. You don't want to figure those things out as you're in the middle of the process. So you want to have these things in place beforehand and come up with a playbook so this way, you can share it. Everyone knows what their roles are and what they need to do. So how do we go from that? So we look at toolkits, right? So we want to have a field guide. So this way the whole team has the same language, the same, checklist, ready to use, throw in place. I think of it like a Braslo tape, right? So Luton Braslo tape that goes by the child. It has height to weight. This way you know what medications, everything is, and you don't, because when in an emergency, the last thing you want to do, whether it's a CPR card, whether it's those things, you want to work on the things, the 80-20 rule. What can we get right? So you don't have to think about it. No one has to think about it. Everyone's on the same page, even for those people who've maybe never gone through this before. So let's review. So things we want to look at is we want to look at things like what's our 5S model, right? What does that mean? How do we share that information? Sorry, 4S model. How do we share that information? How do we look at that? So we want to look at what staffing. We're going to go deep dive into what stuff may need to be thought about, what space, and what systems. And to be honest with you, one of the things I always recommend, and I know we have, is that if your power goes out, do you have a quick reference guide? Is there a way that everyone knows what they look at? So when we put together the toolkit, how's there a quick reference guide so this way you have it? Then in this toolkit as well, which we'll give you access to at the end, is your pediatric readiness, right? Is there somebody, did you identify somebody who is a champion in the role? Are they ready for that pediatric readiness? If by chance 12 kids walk in at the same time, because I'm going to be honest with you, I have a wonderful family we see in Mount Prospect all the time. This nice family has 9 kids, and they come in all the time together. And if you're busy and you have an event down the street, if there's a festival, if there's a parade, if there's anything, how are you ready for that upshoot? It also goes over case studies. How do you do your training? How do you practice this? What cases do you look at? So I want you to take time when you look at this toolkit to not do it in the middle of an event, but to really think about what tabletop exercises can you do. We do this for lots of other things. We do this for other events. Those of us who've done ER work, you do tabletop for other surges, for incident debriefing. How do you do that? And debrief, I usually like to say do a hot debrief and a cold debrief. So after a large event, I always get the team together to say, what do we do right? What did we do wrong? Like what do I need to know? What do we need to change? What do we not have? What do we have? Every time the power goes out, I always have these debriefs on those, or our EMR goes down, and because of the internet, and then we're switching to paper. It's always, do we have enough, information? Did you have everything ready? Something simple like, did you have enough, printable scripts for some of us who switch that? Where if the printer and the internet all go down, are we able to print those? Do we have a few ready? And then the cold debriefs, thinking about the day after, the next day. Do we have enough supplies? Talking with the other teams, if EMS or the teams around the community partners, did they get enough information? Did they get those information for the cold debrief? And then you want to have a major event preparedness checklist. You want to think about these mass casualties or these mass gathering instances, whether it's a football game, whether it's just, if you're in an area where they do a lot of sports, are they having tournaments on a regular basis? Is there things you need to know? Is it, July 4th, the 250th, anniversary is coming around? Is your town doing something, two or three times what they normally do? Is the parade route going right in front of your office? Is there things that you need to know because of that? And like I said, I always, and I love trees, but having printable forms, because being somebody who has been in the office when the internet's gone down, the printer's gone down, the power's gone down, things like that, having those printable forms, just a quick thing. And every, 6 months, look at them. Have laminated command cards of who's got what role. I always love one of the things we like to do is when we're talking about our education we give for in-clinic resuscitations or in-clinic emergencies is the front desk job to call EMS. What questions do they have? We have laminated cards of what patients walk in with, what issues do they need to get the clinical support staff back and do point of care, pulse oxes for those patients. Those are laminated right by the front desk. This way everyone knows, if I don't remember, I can look over, it's right there. So things like, laminated cards of what to do during an incident, what role I have to do. What do I, if I'm calling EMS, if I'm helping, the teams in the back, because I'm front desk and I'm not clinical, what do I have to do? Or even if I'm clinical, we have a great tackle box for anaphylaxis. Inside of it's a copy of our laminated guidelines. This way you're not looking on the internet for how much of this medicine to give. So you have those things that are critical printed with you. So those are things in the toolkit, and you want to look at like I said, the 4S framework. So in an overview of this, you want to look at your staff. Who's delivering your care? You know, do we need to cross-train them? Is your front desk able to help out in the back, at least identify some of the equipments? While everyone's in the room, can they bring the oxygen? Is there all their staffing? Are you able to upregulate with telemed? I mean, if you're a large enough organization, do you have almost like a mutual aid, where if you're in one state, one clinic, can another clinic help you? One of the things that I'm lucky in our organization we do is we do OVRP, which we call that. So it's office visit remote provider, where if it's something like we have 19 patients in the back, but 2 or 3 patients have a rash that don't need to have a physical exam, can we switch that to a telemed visit instead? So this way, they're not waiting a long time because the provider's in with the resuscitation or they're doing, complicated lacerations. Or do you have your staffing? Can you have patients come back, or do you call some staff in? Do you know that there's, where's everyone located? If everyone's an hour away from where your clinic is there other staff who are closer who may be able to come in? And we talked about, mutual aid. Then we'll talk about stuff. So what par levels, what needs to be, What things do you need to have make sure, and how fast do you go through those equipment, your burnout rate? I mean, if you're using things, if you know, like I said, if you know that it's a heat event, it's going to be 90 degrees next week, and you have 2 or 3 marathons or half marathons or other runs or things like that right in front, you may need more ice packs, because this time of year you usually use, 2 or 3 of them a week. And so think about that. What stuff do you need? What space? I mean, what flow dynamics? Where are you going to put things? Zoning, you know, are you going to use are you going to use your other rooms you may not use? Do you have a break room that can be used if you have an upflow of patients? Do you have a room in the back that can be used for overflow? Are you next door to a place for those? And then systems, right? That you have the systems in place that everyone knows what their jobs are, they know what they need. And are there other systems that can help you? Are there other, where is the nearest, let's say you use one emergency room that's closest all the time. Are there 3 other ones that are a little bit further? But if this way, if you inundate that one, you can then move out to the next one. That's one of the things, speaking of a system standpoint, that we do with our emergency department accreditation for pediatrics is, not only we give a list of the distance of each one of the hospitals from in your region. This way, in their capacity, what are they able to do? What are they good at? What are they not? Having that list of the resources and what systems, even if it's, let's say you're part of a health system, that's great. But what if that health system gets overwhelmed? And so this is what we're talking about when we're talking about speaking the same languages. So you want to think of your tiers, right? When you're surging, you want to think about whether it's, elevated, so you're above normal, so you're seeing 10% more. You're giving, you have an internal, heads up to your team. Maybe your operations manager is not in, maybe they're your operations director, saying, hey, just want to let you know that right now we're seeing 10 to 20% more today. Is there other resources we need? Do you need another clinical support staff? This way we don't burn everyone out. Is there another way to offload some of these patients to maybe your other clinic that's a few minutes away? Is there ways to look at the board to see if you can address those? Then, when we're starting to talk about when we get a higher level, right? This clearly exceeds your capacity, diversion, and multiple stressors. So first, seeing somewhere around 25-30% increase, and it's consistent over several hours, and you don't have the resources, you're starting to get overwhelmed. Do you call in backup? Do you offload? Do you need to activate an incident command? Do you have to say, I'm working clinic right now, I can't control these? Do you have to get your operations manager to come in to say, listen, you need to help offload this, you need to really take care of it, be incident command, because you're in busy taking care of patients. Sometimes we need to do that. And or is there, notify if you have a mutual aid, is there have, public health because you're overwhelmed. And then really when we get to the point where we're really in crisis, so we're seeing hundreds of patients. We had unfortunately a shooting in Highland Park, pretty close to some of our clinics, and that was one of the things where you can get overwhelmed really quickly. The emergency department's overwhelmed; they're turning everyone away. And so, is there crisis standards? Is there things are you aware of doing how you do jump start and start triage? And diverting and transferring and requesting for aid, or telling some of your patients, we're overwhelmed right now, it's going to be several hours, can we see you the next day? Can we do those things to multiple patients and then decide who's going to be seen when? So having that same language is important. So let's go a little deeper into the 4S's that we kind of talked about. So we're going to talk about is, our staff, who delivers care. So you want to look at whether it's your cross-training your clerks to do the MA task, which providers can help with bottlenecks. Do you have 3 providers and one back staff, how each one of them can help deliver care when it gets an emergency? Is there a directory? One of the things the toolkit has, which I'm a big fan of, is, again, is there a directory? How do you get a hold of staff if you need to? Do you have their numbers? It always boggles the mind when people are saying, oh, do you know Jill's number or Jim's number? That should not be so hard. It's 2026. We should have numbers listed, how far they are, where they are, those kind of things. This way you can get that backup if you need to. Making sure you have the staff that needs to. Is there other things in your area that you can use from staffing, other clinics for staffing? Do you have three of your staff at one clinic, but you're getting, killed right now and it's 10 minutes away? So you do, you say you have that staffing flow to your site or so on and so forth. Or if you work next to another clinic or if you're associated with even think outside the box. Some of the urgent cares that I know have urgent cares that are focused not on medical aspect of urgent care, but have other um, clinics that are associated with them that can do other things, orthopedics or other things. If they're not busy, can their staff float to you? Can you cross-train the orthopedic, clinical team to help you with, general medical things because you're getting overwhelmed? Or if you're using, have a wellness or a wellness clinic that does Botox and injections and things like that, which is great, but they're not getting busy, but you're getting killed. Can you cross-train their staff for that? So that's how we look about our staffing. Then this goes back to stuff. Do you have the equipment you need? So it's good to have, a surge supply checklist. We keep these in a box. Do you have the right PPE if things happen? Do you have the medications you need? If you notice that, it's croup season coming from a pediatric standpoint, do you have enough medicine like Decadron on hand that you give or albuterol on hand? What is your utilization of those medications, that you have? Do you have enough for your, diagnostic testing? We deal with this every year when we look at respiratory season. Our ebbs and flow change so much so in January and February versus the middle of June, but our splinting material in the middle of June changes. So make sure you have par levels, but also are the par levels need to be flexed? Do they need to change depending? And keeping a list of that. And nowadays things are easy. You can make an Excel spreadsheet that has, pop-offs that change color if you're getting low, and you can have them for different months. And then also making sure that you have a good burn rate of, how much of your PPE equipment are you going through. We know that there's going to be different evaluations of testing or things like that with regard to, we get ebbs and flow for us with regard to pertussis, where we end up using a lot more equipment and special tests depending on those. So we went from staff, we're looking at our stuff, what do we need, making sure that we're not over. You don't want 90 swabs you're not going to use, but make sure that you have a good par level what you do need. So moving to the next is just space. Are there other rooms that can be used? Or do you have enough rooms? I mean, we have 2 rooms that are used for procedures, but of course, if we're hitting a surge, do we utilize those rooms? Can we convert, your break room into having patients sit there or wait? When sometimes, the capacity really increases. One of the hospitals I worked at once used the general waiting room for the hospital across the street from the ER when it got in large, surges. Are there other areas that we can use? Is there capacity? Let's say, think about these from a cohort standpoint, pediatrics, families. If you get a large bunch of, we have a great adventure here. Sometimes, you can get a bus incident where there's several patients come in because of that, and they may not have parents with them. Do you have a place that you can, put them all together and waiting for those people that can be watched? Is there, overload, is there telehealth that can help? So at what space, whether it's virtual spacing or whether it's actual spacing in zones, and pre-think of those as you go through for, surge, especially when it starts to come to that higher level 2 or level 3 with regard to capacity. And then systems. So, when we think about systems, how are they coming together? How are our systems coming together to look and to address these needs? Those of us who are with the luxury of having large systems that can ebb and flow, that's great. But is there other systems, other areas that you can think about? If your area is, overwhelmed with it, is there other urgent cares in your area? Is there other ortho in your area? Is there hospitals in your area? Or vice versa? Are they, pushing to you? You should be able to set up your incident command very quickly and figure out what resources you have near you, who's going to be in charge, who's going to lead us. One voice is what's needed. And I'm going to be honest with you, while I think that I'm the best voice in the room, if I'm busy doing clinical care, I'm not helpful, right? I can't run the show and then be the person fixing the incident as well. So think about that. Who's your incident command? Who has knowledge of what the triggers are, has knowledge of what areas to send people to, what local resources you have, right? And then is able to help your clinicians do their job, which is clinicians. Is there other external contacts that need to be involved, right? If you're looking at whether you're addressing a heat involvement, a cold involvement, are those emergencies? How do you get your incident command? Did you lose power? Who else needs to know? I mean, simple things. I'm going to be honest with you. One of the things I didn't realize it until, and I know I focus a lot of power outage. One of our sites gets power outages a lot. And unfortunately, everything's centrally located for us. So therefore, sometimes we couldn't even call the electric company because it wasn't associated with the phone number that was associated with the building because the emergency number is the central number. Do you know your account numbers for those things? So this way you can identify if there is an electrical emergency. For those of us who do vaccines, what do you do if if you have a vaccine and you have an emergency? Who do you need to contact? Those information, the CDC does a great job of putting those binders together. Or how do you have your set incident command where you are and posted so this way everyone knows which one and who does what? Because that's going to be the biggest thing is when you're in the middle of it. It reminds me of remember when you first learned CPR and you always say, you point at one person to say, you go get EMS, you go call 911. Because if you just looked up and said, someone call 911 and you turn around, the same people are standing there because we didn't direct it. We need to have identifiable roles, who's doing what, and that's important. So we went over the staffing, we went over the stuff, right? We went over space and we went over systems. So you have that shared process and workflow. So this way you know where you have the people you need, you have the things you need to do the treatment, you have the space where you need to, and the system-wide glue to help that all work together. So now, near and dear to my heart, pediatric readiness. Now, we talked about a lot of issues, we talked about a lot of things, but I'm going to be honest with you, when you talk about pediatric readiness, it is a different population. I'm not just saying that because I'm a pediatrician, but it is. Things that you have to keep in mind is one, they may or may not be able to tell you what's going on. Their parents may or may not be there. It may be aunt or somebody else coming in, and you have a large swath of patients coming in. In an emergency, do you have a weight-based dosing, right? So you can easily, quickly figure out how much the patient, if there's an emergency and you can't move them, how much they weigh, so you can give the medication they need. Do you have the right size equipment? Do you have, if you're going to be doing advanced or keeping advanced airways, do you have those? If that's what you want or where your system asks for. Do you have PPE that fits them? Do you have appropriate masks? This way, when you're not, if you have 25 people in your waiting room, so this way they have the appropriate, PPE to wear while they're there. And it works for them. Remember that when you have lots of pediatric patients in your waiting room, the fact that they can't tell you means that they can also decompensate quickly in front of you and you won't know. So do you have a way for your front desk and your front staff to be able to identify, to look to do, or are you doing rounding on those patients and if you're overwhelmed? So you can look to see if your pediatric patients are decompensated. Because I'm going to be honest with you, they really think of it almost like the if you ever walk outside of a beach and you walk in and all of a sudden you hit that ledge and then you're down 10 feet. That's what's going to happen. And they can tire out really quickly. So if they're increased work or breathing, are you addressing it? So I usually have processes in place where patients who present and say that they're having respiratory distress. A lot of parents say that, but get a pulse ox on them. It takes a couple of seconds and cross-train your front staff to be able to put a pulse ox on them, and then just say, okay, well, we have a pulse ox looks well, the respirations look good now. So, and then we can reevaluate, but right now there's not in distress where you need to be brought back right away. And parents are concerned. Parents are scared. I know that everyone gets this view about pediatric patients. They get all overwhelmed with pediatric patients. They say they don't like the parents. The parents are scared. Most of the time, they're just scared. They're not medical. They're scared about what's going on, and they want to be there for their kids, but they don't know what they don't know. No different than if you have a car that makes a noise. If you're not a mechanic, you may not know what that noise is. That may be something worrisome, or that may be something that's, it's a wet fan belt, and it can be making a horrific sound, and that's why parents are scared. They don't know if this is a needs to be brought back right away or not. And that increases anxiety for all the staff. When parents are anxious, the guardian's anxious. Maybe it's a grandma who's taking care of the child and doesn't know this child has, you know, gets croup every month. And these are normal like breathing issues that they have. And this is something that they bring in and the child's fine. Or they're watching them and they don't know that they have reflux and they're vomiting. All these things that, guardians, they're not sure what's going on. And do you get consent? Do you have consent from the family? Do you have chance of unaccompanied minors come in? Those are all things that make the pediatric population different. This is why designating a pediatric champion is important. If you look at EMSC, so emergency medicine for children, if you look at everyone and whether they're looking about inside clinics, whether they're looking at urgent cares, when they're talking about emergency room, having that person who is able to understand and really get the capacities and what the emergencies for pediatrics is important. So having that pediatric champion. Also, this way, if people have a question, they know who's that resource for that. No different than if you have, a stroke champion. No different than if you have a sepsis champion. No different than if you have any one of those. Who's that person who knows what equipments, what needs to be done, what other things and training and drills that are special for pediatric? To be honest with you, they're also the voice. Whenever you do let's say you're doing, surges for adults, it's that person in the back the champion who raises their hand and say, wow, this is all great. What about the kids? What do we do if kids walk in? Oh, we don't normally see it. What if they do? What do we do if they do? What if you do if that patient walks in a snowstorm and they can't go anywhere else? I mean, the other thing too is we get tornado watch. I know that doesn't happen as much in NERUCA territory, but we get tornadoes. So, we get patients walk in and, it's not safe for them to go outside. They need to stay in. And if it's a patient that we're not usually seeing, we're carrying, we don't see we see pediatrics, but we don't see adults. But we started carrying aspirin because when adults come in, we want to make sure that we're meeting them with the things that they need. The same thing should happen for your peds patients. Practicing them, make sure that you have protocols, pathways, keep them up to date. Every 6 months, just look at them. I usually say always put a date on the bottom. This way everyone knows when the last time somebody looked at it and update it. Because things do change. What resources do you have? What liaisons or what family people. So that pediatric champion is that designated person who says and agrees that this is a population I know. I will keep up to date with it. I'll also address the needs, and that's what you want. You want somebody who understands that population and wants to deal with it. So checklist for capacity, right? So you want to look at your checklist for pediatrics. So with the prior grant, NERUCA did a great job with the pediatric readiness checklist. So it's actually very in-depth. It looks at what organization preparedness, clinical protocols, equipment, supplies, quality assurance. Are we addressing those needs? Are you getting, from a pediatric standpoint, are you looking at your dashboards? Are you doing quality metrics? Is your pediatric readiness person, that pediatric champion, are they reviewing 2 or 3 charts of pediatric patients that you see every quarter or every month, depending on how many you see, and just making sure that, the pediatric needs are there? Are we doing, vitals, including SpO2? Are we getting weights on everyone? Things like that. Are we doing those things that need to be for that population? Because that's going to be a little different. Are we making sure that allergies are confirmed? I'll tell you, one of the things that comes up all the time is that people don't confirm allergies in pediatric population because they're used to adults where if there's a new allergy, they'll tell them. But if there's nothing that's changed in the last 20 years, a lot of times we don't ask. So keep that in mind. Something simple like that. Do you have different, do you have appropriate ways of figuring out the medication dosing for pediatric populations. If you're seeing a decent amount, are you keeping suppositories too for the patients who can't, take those? Are you have the staffing having training on what's the difference between pediatric and adult population with regard to the amounts? Care coordination referrals, where do you send those patients to? Knowing who has a PEDS resources, and how they change. The closest uh, hospital to one of ours had a children's hospital affiliated in their pediatric ER, and then they decided to get rid of that and get rid of their PEDS unit. So that's one of the things where, we're now transferring 5 minutes away, and it's 5 minutes difference, which isn't a big deal. But because we know that if you're going to be admitted, you're not going to be admitted to that hospital. They have no PEDS capacity. The other one does. Or, does that pediatric hospital, that hospital you're sending them, do that PEDS ortho? Like knowing what things you have, and every 6 months just check and say, hey, did something change? And because they may not always notify you, so having that champion, naming them, making sure they run the checklist, making sure they're looking, and any gaps that they notice, are they addressing it with regard to tools, equipment, protocol, training? Are they evaluating and drilling and reviewing those? And make sure that the PEDS voice is always there, and looking at the quality improvement cycles, making sure that they're reviewing charts, making sure that the pediatric patients are not getting medications that they usually shouldn't get, that they're not getting, we've, from almost every disease process, we've decreased the amount of antibiotics, and that's my other hat is antibiotic stewardships. So for things like cellulitis, things like that, impetigo, we're not doing 10-day courses of medicines anymore. So are they doing appropriate for urinary tract infections? We've drilled down to almost, if they're above 2 years of age and they don't have signs of pilo, to what we're doing for adults, 3 to 5 day treatments, up to maybe 7 days if they have some other increased risk factor. So are they doing the right medication education for those patients, and picking those populations to do a quality improvement checklist on, and say, hey, here's a great article, that's from the AAP that's looked at the dosing and the time intervals for this pediatric population for ear infections if they're above 6 years of age. Actually, 5 days is fine as long as they have no risk factor. They haven't had an ear infection in the last month, and they don't have any craniofacial abnormalities. You can do 5 days. So having those quality metrics, choosing one. Don't. The other thing one of the problems I see is that people get excited about this and they try to change 50 things at once. I don't recommend that. Put one thing in place, take the time to address it, take the time to look at it, and then go from there. The next thing is rehearsal, training, right? Mock codes. What are you going to do? Who's going to grab the oxygen tank? Do you have to teach the front staff what an oxygen tank is? Because if you're in the room, even with an adult or something, if you're in the room and your clinical sports staff are in the room, and everyone's trying to be leaner, which we understand because of reimbursement and all issues that we can't address, you may not have those 3 or 4 extra staff in the back that can help. Are you in a room, your clinical sports staff's in a room, and you're asking your front desk to grab the oxygen? They have no idea what that is. Just simply having them identify the equipment, doing mock codes, bringing in what's needs, whose role it is to call 911, whose role it is to give handoff, and then again, how do you address that? What cold debriefs, what warm debriefs? Did you notice that actually no one knew where the key was for the code card, or we didn't have this in our box anymore. We recently had somebody in our clinic, one of our providers, go down because they've had a stone, and we were putting IVs in and realized that we actually, because of a shortage, we didn't have any Toradol, but no one knew. So things like that, those mock codes help you know what equipment's missing, what do you need, what do you not need. Are you having tons of equipment that you'll never use? Is it hard to get to the equipment you need? Look about if you have those, ED diversions, if they're sending people to you, if you're going to try to help them. How do you address that? Do you know how to do jumpstart triage? Do you know how to identify which patients really need to be seen sooner rather than later? And space, like I said, if you're lucky to be in an area where there's a large amount, or maybe you have, like I said, a connected health spa that that you could surge to because they close at 5 o'clock and your clinic's open till 10 o'clock. Could you surge there? Could you off-site things? Could you get into that area? Is that a great way to do? Or do you have a daycare or an adult, nursing home, somebody next to you that literally could by chance send 10 patients across to you? And how do you address that? And how do you address those needs? So those tabletop discussions, practicing it. So this way every person, and the other thing is, even when you think you have everything down pat, remember you have new staff all the time. That's why these are important so everyone understands their role. Because if they are, especially for a lot of us, we're training our new staff because they're coming from areas where they didn't do this, especially front desk or your clinical support staff. If you're lucky to have seasoned nurses, that's wonderful. If you're getting an MA who's really learning while they're there, you know, how they ever learned what capacity is, what's tabletop exercises, what did they grab, how did they grab it? So constantly doing this, as much as possible. I again, those are important. You know, again, just run the code, debrief, and what actions, what's learned, and then rerun it later. I would argue the only thing I would add to this is with the debrief, you do a warm debrief, so right afterwards, and then a little bit later. Also, I will tell you one of my problems with debriefing is that I'm loud. I always say exactly how I feel, and sometimes us loud people can take over the room. And there may be great insight from people who are in the room who just are not as uh, let's say from New York City as I was born and raised. And so you want to also give them an ability afterwards to send a cold debrief and say, hey, we talked about A, B, and C being things we need to do. Is there things that you thought about or didn't want to say or need to talk about that may want to add to it that you may want to say that we need to do in these, instances? Is there things that, from a cold debrief, the days later you think about? Sometimes we mull on it, or like I said, sometimes that person who has great insight, but is more of a, not as much of an outspoken person as I am. And then, like I said, the what I really look at is the 3 A's. So adopting, adapting, and abandoning. So what are we going to set up? What can we do in the next 1 to 30 days? If you're seeing a decent amount of pediatric population, give or take, if you're seeing 20%, which is the population in most states, do you have somebody who's a pediatric champion? Is there, triggers? What is your number of your capacity? If you have 9 patients in 30 minutes, but you have 4 providers, that's fine. Or you normally have one provider and that 9 people, patients coming, is it your trigger for going from tier 1 to 2? And those staffing directories, I mean, these are easy things you can do. Like we always say, what can you do by Tuesdays? You want to have a thing, one thing to do by next week, one thing to get started, and then one thing to, the bigger things. How do you to address a pediatric champion? Maybe that can take a few days, or a champion who likes to do disaster preparedness and things like that. It doesn't have to just be peds. Then for your 30 to 60, what equipments do you think you need? What spaces? What things from the checklist do you think that you need to address? And then, rehearse it on a basis. Set these things up, say, hey, you know what? This week, every year, let's say you're always, have a low July 4th because people are away in your area and it's a transient community in that sense that people go and they don't. Is that a good time period? Maybe not the 4th, but sometime during that next week to do this, or in the next month. So things, you want to instant lead your pediatric champion, logistical supplies, communication leads, who's going to talk, one voice to EMS, the hospitals, public health, training coordinators, who's going to be in charge of the training, the desktop discussions, and who's going to own it. Because I'm going to be honest with you, if your exec team doesn't have the backing behind it, if they're not the ones who are there, if they're not the ones who think that this is important, your rest of the team's like, well, Jim wasn't here. He doesn't think this is important, so why do I need my effort? So you really want that executive buy-in for all these processes. It keeps everyone knowing that this is something that as an organization you think is important, and it keeps everyone knowing that you're there to step in, and you know everyone's role too. Think of it like a conductor who can kind of play everyone's instrument, but doesn't do it as well as them. So to know, wait, what is our burnout rate? Hey, how do we check for burnout? Joe or Jim is away for a week. Who's going to be the person to, every week, or they decide to go, to Greece for a month, and so we know these check things need to be done each month. As your executive team involved can say, well, I'll step in for this month because I know what needs to be done. So again, start this week. Name your 2 leads. Look at your instant leads, your pediatric champion leads. Look at communication leads. What thresholds are you for your triggers? So this is a good way of thinking about from start to finish in the next week or two, things you can easily address and easily have wins on. If you need to fill out staffing directories, what's everyone's number? I'm going to be honest with you, when things go crazy, you may not know. I would even argue putting the distance doesn't have to be there, how far they are from the clinic. So that, if you're up here in like Wappinger Falls, upstate New York, and the staff that you have there is, New York City traffic, but 20 minutes, 20 miles away, it can take them an hour to get here, especially on a busy, morning, or, during traffic times, gridlock. So where they are, how to get them in, and what staff may be closer, may not, maybe somebody who doesn't always, we have somebody who works for one of the she works for one of the pharmaceutical companies, so she doesn't do a lot of PRN shifts, but she's one of the ones who's always can pick up or come in if we need, those surges. Even identify a surge team. Those 3 or 4 people who you can send a text out to say, hey, listen, we're at 20% more than we normally see. Can you come in for a quick, win, for like, 20, 30 minutes, see a few patients and come out. Laminate the command cards, and then, book that first tabletop. Give everyone enough time to be there. So these are some of the resources that are in place, that are set in the toolkit. So you can look at emergency staffing, space assessments, pediatric readiness checklist, the surge tier definitions, supply list, incident command, tabletop instructions, and the mass gathering checklist. Okay, I'm going to leave it to Sam for questions.
Thank you so much. I really appreciate that. That just about concludes the presentation. So thank you so much, Dr. Dolan, for that lively discussion. We're now going to go ahead and open up for Q&A, a brief Q&A session. So as a reminder, feel free to drop any of those questions that you might have using the Q&A chat box at the bottom of the screen. And we're already seeing some good questions come in. So I'll go ahead and I will share those out loud. The first one that I see is about staff, and it says, during a surge, staffing is usually the first challenge organizations feel. What staffing strategies have you seen work particularly well in urgent care?
It's a good question. One of the things that I've seen that I actually like to mimic was done out of a group that would have that text. So they had a text chain where they would literally send out a text to their whole group and say, you know what, we have 9 people in the waiting room. If anybody would like to come in for an hour or two, text us right back. And they did. And then, you don't feel bad. Like you're out and about. You're like, for me, my kids are, now 14 and 16. Sorry, their birthdays were last week. So like if they're doing their things with their friends or things like that, the clinic's 7 minutes away, I could pop in for an hour and two and get those, to help decrease that burnout for everyone else. Maybe even let people just like take a breath, go to the bathroom, have a soda, relax, have something to eat while they can decompress for a little bit. So I think those surge teams, those surge text teams are really helpful if you can identify, if you have the capacity.
Great response. Another one come in and it says, how often should organizations reassess surge inventories and PAR levels?
It's a good question. I really think it depends on what you're looking at. So I will say that during PAR levels, I would say you need to do it a few times a year at first. And I'm not trying to mean, but the reason I bring that up is if you have a system where you're already checking stocks and you can look stock of things and you can look back and see, that's perfect. If you can't, the plus is are you surging during January for, this equipment? Are you surging for ice packs in the summer? Like, you don't want to just check it on once in a blue moon. Really know when your surges are. So I would recommend at least every quarter. And if you have an interactive, obviously, a system where you can actually look at it, and some of the companies have those, it would be really good to actually take a moment and look at those dashboards.
Great. Thank you so much. So I know we talked a lot about training and exercises and the importance of those. A question came in about urgent care centers saying that they often don't have time for drills. What would be your response to that? And how can centers make tabletop exercises more manageable?
It's a good question, and I totally understand that. So what I like to do whether it's tabletop or scenario, I like to get everyone, at least in the clinic that day. If you can get them to come in, 10 minutes early. If they're doing, especially if they're doing split shifts and they're not doing a 12-hour shift. We used to do this, 5 minutes before we opened. We would do a walkthrough with a patient presenting, and we give them a picture, show them the picture of the patient, and walk through what they would do, who would care either what. If it's a tabletop, you can do the same thing. It just takes a few minutes before the clinic opens, is what I say. If you're one of those who have a downtime in the day, some clinics do have downtime in the middle of the day, you know, think about that. If for us in pediatrics, when school's in session, usually we get the bump for parents in the morning who have little babies or kids don't go to school. Then we get them when they come out of school, right? So in the middle of the day, a lot of times you'll have that little bit of a lull. So take the time to do it during those lulls. But you need to take the time to do this, because if we don't put the effort into it, it's the old saying that if you don't have time to make it done right the first time, are you going to have time to fix it? You don't want to figure this out in the middle of a surge. It's going to take a lot more effort. So really practicing getting everything together is just better for everyone.
Really great points, Dr. Dolan. So I think that's probably about all the time we have today for questions. But don't worry if we didn't get to yours, or if something comes to mind later. We're always happy to continue conversations. So you can always reach out to us directly. And as Dr. Dolan mentioned, so this medical surge preparedness toolkit that was specifically developed for the urgent care setting will become available in the coming weeks for any interested urgent care center who would like to use it and access it. So please do feel free to reach out and let us know your interest, but we'll be sharing it as well with our membership. And so I'm happy to close us out. To Dr. Dolan, during today's presentation, thank you so much for partnering with us on this very important topic in urgent care medicine. It's been an absolute pleasure learning from you. And to all of our attendees, thank you so much again for your time and attendance during today's webinar. We hope that you found the session insightful and valuable. And as I mentioned, the recording from today's webinar will be made available on our YouTube channel in the coming days. So we really appreciate your participation, and we look forward to seeing you at our next session. Have a great day. See ya.